We thank Medtronic because, not only because they have arranged this this symposium, many workshops, but always to put a lot of attention in the problems of infertility, because this is not something that happens for all the company, I have to say. The interest is, of course, to sell the device, to show that some devices are better than the others. But what is important is the careful attention to patients and not to create damage with the instruments that, of course, they are going to sell and we are going to buy and to use in our clinical activity. To be honest, I'm very happy to chair this symposium because for me, and you will see later in this room the Heart to session, I strongly believe in the importance of uterine factor. And sometimes people dealing with infertility problems are always scared. Sometimes it's an alibi, sometimes it's truth, that if you do something inside the uterus, you can harm the uterus. I have many colleagues from IVF say, oh, no, don't do hysteroscopy 3 months before the transfer. Why? I can only improve the pregnancy rate, not reduce. No, please don't touch the endometrium. There is this conviction that if you go inside the cavity, you can create problems rather than resolving problems of the lady. So the title of this symposium, Optimizing Fertility in Uterine Pathology Removal, it's important because you will see in the next session, we still discuss if when we do something inside the cavity, we improve or not the reproductive outcomes. And you will have 3 leaders in this field that I think that they represent at the moment the figure that I put as model for my young trainee. And not honestly because I'm here chairing themselves, because the modern gynecologist is not only an IVF specialist, as Lawrence will be the first speaker, is one of the most important IVF specialists, but he's also a great hysteroscopist. And I'm sure that in his clinical activity, he's also a good sonographer. And this is mandatory to have good results in your clinical activity. Then I will introduce then later even Noah and Ursula that are part of my heart because we share our first experience in hysteroscopy in IVF. I was happy that Noam spent a period of time in my team. And since that time, Noam, remember, I told you, you will have a success because you are very talented. And I'm happy that I was not wrong. So, Lawrence, you are linked to one of the countries I am more related, so South Africa, even because I spent my honeymoon there, despite my wedding did not go well, but okay. The honeymoon was fantastic in South Africa, so I went for safari, so you come from Johannesburg, and Lawrence is one of the leading experts in infertility, IVF, hysteroscopy. And I have to tell you that the first webinar that we arranged for Medtronic, Lawrence, we were me, you, Justin, because you have been one of the first to adopt this technology and to believe in the importance of tissue removal device, mostly in infertility environment. So the stage is yours. I spoke too much, but in the meantime, people came in the room. This was the intention.
This is a good move. Am I on? Firstly, Attilio, thank you very, very much for the introduction, and thank you for the most brilliant conference. And it's, I think, my 3rd one I've been to, and I can't believe how the numbers have just skyrocketed. And hopefully we could get to ESHRI numbers, one day, 12,000, 15,000.
Don't say. We can do always better.
Absolutely. So my discussion is optimizing intrauterine fertility using advanced techniques in submucosal myoma removal. I have been doing endoscopic surgery for 44 years, and I had to obviously in the beginning use a resectoscope. But when I was introduced to the mechanical tissue removal device, I certainly went immediately over, and I'll show you now one place that I do use the resectoscope, But at the end of the day, I'm going to concentrate on fibroids and my technique that I utilize. So my disclosures, I do report receiving personal fees from Medtronic for lectures and consulting on hysteroscopic morcellation outside the submitted work. But I have to tell you, and the picture on the right is for Sergio, I'm passionate about hysteroscopy and at trying to make the abnormal uterus normal. And as Attilio said, we as fertility specialists, we're not scared of making that uterus normal. There's been a lot said about fibroids and infertility, and we all refer back to Elizabeth Pritz's article where she shows decreased implantation rates, clinical pregnancy rates and live birth rates, and an increased miscarriage rate. And I think that, I know so far no one's really spoken a bit about volume of the fibroid, and that is something that should scare us more than the fibroid. But what's important is our top image over there, and you need to know, and I mean, we just addressed that ball. I think it was Attilio that showed us the ball on the guitar strings. We did look at the strings going up, but we mainly looked at the golf ball. And at the end of the day, there's the pseudocapsule, and the pseudocapsule has nothing to do with the fibroid as such. It's a mechanical thing that has been formed in the myometrium. And it is attached to the fibroid, but it's not part of the fibroid. And we know most of these fibroids are intramural, and some of them will move out depending on the contractions of this myometrium to subserosal, and others will move out to the cavity. And we need to use that in the work that we do. Now, do we really know what's going on in these fibroid uteruses? Do we? We don't. And the uterus is full of blood vessels. The uterus is full of nerve fibers. It's full of a whole lot of proteins and vasoactive substances, etc., that I don't even think we think about it. We go in there with a bull in a china store and we just grab out what we've got, and we go to sleep at night thinking we've done a very good job. And yes, we saddled with our monopolar, we saddled with our bipolar, and what else can we do? So, and I go back to the days where I would use just a scissors and a grasper. And I would do exactly what Sergio said the other day, that I think it was yesterday, just remove the fibroid and then leave it in the cavity. And hopefully something will happen. It'll either fall out or degenerate, or patient will moan about a discharge. But gone are the days where I had to sit there after loosening it, grabbing it with an ovum forceps and pulling it out like you were popping a champagne cork. I don't know how many have had that before. Put your hands up. A couple, yeah. And that really is not fun. So you have Attilio's article, not Attilio, Sergio's article in 2015, and then we have Stefano Bertocchi's article on the opium technique, where you chop it up, and the patient has to undergo a second stage procedure, which does not really do well with our IVF patients. They want to get pregnant the very next day. So at the end of the day, when we look at this picture, fortunately, this is not a pilot who's flying in the clouds, because he would be quite disorientated. And the only reason you know what's up and down is because you're holding the scope outside. But that's what you've got to deal with. And at the end of the day, you know, is it what we should be? And the one issue with that is that with doing resectoscopy, we got into uterine adhesions of somewhere between 4 and 12%. And what is important is you give a complete resection with resectoscopy of in the region of 85 to 99%. Now, everyone's heard today and yesterday and the day before about the pseudocapsule. And at the end of the day, there was a paper that presented in JMEG by Loffa, which said, complete resection of submucous myomas may not be necessary to achieve the desired clinical results, because spontaneous regression may occur. And at the end point, this actually just justifies poor surgical technique. And you've got to go with Keith Isaacson, and it was great to see Keith getting his award yesterday. Complete resection of submucosal fibroids is the standard of care and is unequivocally supported by the literature. Any deviation from this principle should be discouraged because it represents suboptimal patient care. And at the end of the day, the pseudocapsule should be our friend. And we know when we do a laparoscopic myomectomy, we incise the serosa, we hold our breath for the blood that's going to come out, and get that fibroid out after resecting it off the pseudocapsule. We do exactly the same. And at the end of the day, this pseudocapsule is full of neuropeptides, neurotransmitters, and really you need to respect the uterus, and we need to respect the pseudocapsule. And we know with myometrial wound healing, there are 3 complex and overlapping phases: inflammation, tissue formation, and tissue remodeling. And mediators of inflammation and wound healing in the myometrium are contained within the pseudocapsule. Please don't take it out. So here we have the one and only time, sorry Medtronic, that I will use a resectoscope. And that is when I've got a long prolapsed Figo 0 fibroid that's out the cervix with its long, thick pedicle, or a cervical fibroid that is prolapsed through the cervix, because that's where you've got, in these pedicles, you've got big blood flow, and they bleed profusely. So here we are taking out that prolapsed fibroid with the 15 French resectoscope. So now if we look at my technique of what I do is, this was a surgeon who needed to go back to work on Monday. She had a full list. She couldn't tolerate it anymore. Her hemoglobin was 6, and it was a 4 centimeter figure 1. And all the doctors in Johannesburg told her she needs to have a laparotomy and a hysterectomy, as we all said early on, a rubbish hysterectomy. And she knew about what I did, and she came along, and there I used analogs to get her hemoglobin up. It took us 3 months actually to get that hemoglobin up to above 10. And here we go, where I use the scissors and watch the endometrium, it blanches. And I open the endometrium with the scissors, and I use this as a dissector as well as a sharp instrument, and I use it to dissect the capsule off it. Now, you've been watching resectoscopes doing myomectomies where they've been taking the endometrium, taking the anterior pseudocapsule, and only leaving the posterior pseudocapsule there. So all you do now is, can you move it on a bit quickly? And this lady had 2 previous cesarean sections, so she had quite a big isthmocele, which was asymptomatic, and she had her 2 kids at home. Can you move this? Can you move the video on? So there's the trochlea coming in. So I've created the space. Oh, I'm sorry, no, not completely on. I wanted to just get towards the end of that. Or I'll show it on the next one. So you saw the space opening up, and you saw me bringing in the trochlea. And in this one, we're going to do exactly the same. So this is the famous one where the doctor does his ultrasound in the rooms, and then he puts his fluid in, and he looks at everybody in the theater, and he says there's no fibroid. And the reason why there's no fibroid is the pressure. So do your Homer maneuver, you get your fibroid to stand out, and out you go. And then use your scissors to open up the endometrium, watch the endometrium blanch. I don't know why everybody worries about bleeding fibroids when you manage them submucosally. This does not bleed. And I never have bleeding as a problem. Very rarely, if you're taking a lateral fibroid, which you may be very close to the uterine artery or one of the smaller branches of the uterine artery, you'll get bleeding. But note that, see how thick this capsule is. And the reason for the thick capsule is we know that the closer the fibroid is to the uterine cavity, the thicker the capsule. Beware of that. That capsule is your friend. Don't take it out. And there you use the scissors to get rid of your pseudocapsule fibers onto the fibroid, put your trochlea in. This is the first sign that the lady's not watching my fluid, my pressure's gone down. You leave the capsule both anterior and posterior and move on. this is basically the same thing, and we're starting to get down to 4 minutes, so we're going to move on. Just to show you figures of a small trial that I've done of my own, which is 85 patients. You can see here that between figure 1, 2, and 3, majority. Okay, so that's 21, that's 42, 52, that's 57 are figure 1, 2, and 3. Very few figure zeros. And then there was 11 that had more than one fibroid in the uterus. And the mean age of these patients was 38.2, which is something that's worrying us as fertility specialists, because that's what's crossing our threshold now with the first pregnancy. Our conception rates, if we look at these, and these are patients who only had fibroids as the reason for their subfertility or infertility. Our positive beta was 69.4%. Our ongoing pregnancy rate was 70%, which was for us a fetal heart at 7 weeks. I don't have a live birth rate, unfortunately. Our miscarriage rate was 11.3%, which is quite low, and I think the reason for that is because the majority of the frozen embryo transfers, as you can see here, 53 were FETs, were all aneuploids, were all euploids, and we had a 1.5% ectopic pregnancy rate. All these patients were scanned 2 weeks after the surgery, and the uterus looked like it had never been operated on. I could see no endometrial foveas on ultrasound. It looked like, and the patient looked at me, and I looked at the patient, and I said, no, hang on, is this true? Anyhow, we had 5 of the fibroids opposing, and in that group, funny enough, we had no intrauterine adhesions. We had 13 patients that had both a hysteroscopic myomectomy and laparoscopic myomectomy, with a laparoscopic myomectomy range between 4 and 10 fibroids. And at the end of the day, the 2 fibroids that we did get intrauterine adhesions, I know small study, 2.35%. And that group, I can't explain it because none of those were fibroids that were opposing, and none of our opposing fibroids developed adhesions. And they say if you've got opposing fibroids, do one first, bring the patient back later, a month later, and do the other one. But my thought process is if they're going to need 2 procedures anyway, let's do it. And if they don't get adhesions, at least you've saved them a procedure. This is the scissors I use, which is a Stort scissors. And it's a 5mm scissors. I think when I'm doing this kind of work, I can't afford to use a Mickey Mouse scissors. And I use the scissors showing exactly, as you can see there, you've got your 2.6 centimeters and my 1 centimeter. I have a scan in my theater every time. I will always map that fibroid. Once the patient is asleep, I will have it in my mind. And if I struggle, I use my measurements on that scissors to then, under ultrasound guidance, be able to actually go, and so I fill the bladder up with a Foley catheter, and I'm able to then poke my scissors under ultrasound vision into the fibroid over there, and then I know exactly where the fibroid is. So it's very simple. If you're not able to correlate between what you're seeing and where you think you should be, rather than opening that scissors like a tea strainer, just get in and see exactly where you are using combined ultrasound, and you'll get there. So what am I saying? And I think that Toni Morrison, who was the first black American Nobel laureate, said, doing it wrong isn't bad, but doing it wrong and thinking you've done it right is. So I am pleading today for fibroids. Let's have no electricity in the uterus, because I have had no problems. I can get to any fibroid, and at the end of the day, I'm even doing 4s hysteroscopically. Again, nobody here, and you'll see Medtronic will say do 0, 1s, and 2s, but don't go further. I think you can go further if you've got a mentor that will train you. And let's go with mechanical devices rather. And always train yourself first with the scissors and the grasper, and then you will become competent with your mechanical tissue removal device, or, as I say, your resectoscope. So what we need today is our take to work message, which my esteemed teacher, Mark Hans Emanuel, taught me. He said, don't take your work to home. So I use his saying, take to work message. We need a paradigm shift here. Both the anatomy and the functionality of the uterus needs to be respected, preserved, and improved, and not destroyed. I always say the uterus is for preservation of the species on this planet. It's a very important organ for us. We're trying to prove ourselves wrong as quickly as possible because only in this way can we progress and find progress. And this is Richard Feynman. He's a scientist in the States. Thank you.
Thanks, Lawrence. Now we move to the next speaker. It's an honor to introduce Noam Zmorczyk. He's one of the leading experts in infertility, hysteroscopy, laparoscopy. She is the chief of one department, and I know from her assistants that she's very severe, but she is a very skillful surgeon. And her first patient probably has been hysteroscopy. And many years ago when she came by me, so I told you before, so I saw that she had a real passion. And I'm really glad that she presented this topic because, if I'm not wrong, I think that obstetrical indication for hysteroscopy will be one of the main leading indications for this technique in the next 10 years. And I have to tell you and give her the honor that has been one of the first who has shown the potentiality of diagnosis and treatment of such obstetric conditions by hysteroscopy. And so I'm very happy, and I'm happy that you are here to listen to her. Noam, go ahead.
So welcome, everybody. Thank you, Attilio, for this opportunity to present our study, and thank you, Medtronic. And I will talk about the study that we did comparing the hysteroscopic and suction management for patients with early pregnancy loss. This is the disclosure for our study. It was funded by Medtronic, who supplied us with the trochlear devices, but they did not have any role in evaluating or editing the scientific content of the study. So as you all know, early pregnancy loss is a very common condition diagnosed in about 15% of pregnancies. And of course, we have the options of offering patients conservative follow-up or medical management, but that usually takes a relatively long time for resolution. Patient may still need to undergo a surgical procedure if they have an incomplete abortion or if they have retained products of conception, as can be seen here. And I'm sorry, but this was done with the VersaPoint instrument and not with the trochlear, but obviously you can use tissue removal device to treat retained product of conception as well. So those options are available, but they do have some disadvantages. The second option is to do a surgical management with suction curettage. Usually we do it under ultrasound guidance. It does have the advantage of being widely available. It's a short procedure. It has a very low cost. And there are some surgical complications, but they're usually rare, such as a perforation or a false passage. However, we do see, not uncommonly, the risk of retained products of conception, and even more importantly, the risk of postoperative intrauterine adhesions. And those have been shown to occur in about 20% of patients. There's some very good papers done by the group in Netherlands from Hooker. So those numbers are real. And this is just an example of those adhesions that we can see after a suction curettage for an early pregnancy loss. So I think it's very obvious for us as uterine surgeons that we need something better. This is not good enough for our patients. And when we think about making an intrauterine procedure better, hysteroscopy is really the obvious answer. We know that hysteroscopy allows us to do a selective surgery inside the cavity, so we can work only on the pathology without touching any of the other uterine walls. We can identify uterine anomalies. We can maybe reduce the risk of having RPOCs. We're using small diameter instruments. We nowadays have the ability to enter the cavity using a vaginoscopic approach, so maybe less perforations, less false passage. And lastly, we will also have the opportunity to look at the embryo, assess for anomalies, obtain some genetic sampling. So this is really something that is, has a lot of advantages compared to just the suction. And this is just an example of several cases of embryonoscopy. diagnosing very early fetal anomalies done by a Professor Haimovich, both neural tube defects and other anomalies. So this is a very promising approach. And this was really the rationale for our study. It was a randomized, controlled, prospective study, including 100 patients up to 10 weeks of gestation, all with early pregnancy losses, with no more than 2 prior losses or cesarean sections, randomized into 2 arms, the traditional suction and the hysteroscopy using the tissue removal device, in this case, the mini-elite trochlear. All cases were done under general anesthesia in the OR as an outpatient procedure. And the primary outcome of our study was looking at the cavity after 6 weeks. I'm going to go over briefly the steps of the hysteroscopy because this is really what's novel in the study. We gave all patients sublingual misoprostol just before they were taken to the OR for cervical ripening. And we tried to do a vaginoscopic entry into all cases. This was successful in about 90% of our patients. And as you can see, in a lot of cases, it's really easy. It's very similar to other vaginoscopic entry. However, you do have to be aware that in some of the patients, there is a cervical plug at the area of the internal cervical os, which is different from other hysteroscopy for non-pregnant patients. And in order to enter the cavity, you have to go through the cervical plug, just kind of pushing through it, and then you can enter the cavity and see the gestational sac. So this is something that's a little bit different from just a regular vaginoscopy. After we have the scope inside the uterine cavity, we take a good look, we see where the sac is implanted, we look for any anomalies. And at this point, really before we're doing any of the operative procedure, we ask anesthesia to give the patient IV oxytocin. We have found that the administration of oxytocin before we actually start the removal of the gestational product is what is helping us to keep the visibility inside the uterus clear and to decrease any bleeding. Obviously, the first concerns that people have when they start doing those procedures is visibility. Am I going to have any bleeding inside the cavity? Am I going to be able to complete the procedure with hysteroscopy? And we have found that giving the oxytocin early on before we actually do anything is what is going to be helpful for us to have a good view all throughout the procedure. And at that point, we can introduce the shaver, which brings us to the next step, which is the longest part of the procedure, just taking out all the gestational products, going over the sac. Sometimes we see some embryonal parts as well, going through the decidua that is underlying the gestational sac, but not touching any of the other walls of the uterus. In this video here, the gestational sac is relatively larger, so it does take a few minutes, but as you can see, we have a fairly good view of the cavity all the time of the procedure. And this other example is a smaller sac with an anterior implantation, and this procedure is going to be relatively shorter. Again, we can have a good visibility throughout the procedure. There is a little bit bleeding, but it's cleared up very, very fast. And finally, after we have removed all the products, again, we take a good look at the cavity. We make sure that we have removed everything that we see, and we're done. I'm going to go over some of our results. First of all, the first question that was interesting to us is how many cases are we going to be able to complete by hysteroscopy, and what is going to be our conversion rate to suction? And we're actually surprised to see that among the 50 patients who underwent hysteroscopy, we were able to complete the procedure by hysteroscopy in 48 of them, so 96%. We had to convert to suction in 2 women, again, because of bleeding and reduced visibility. So this was a nice surprise for us. We had no cases of complications such as perforation, no excessive bleeding, no cases of fluid overload. We did have 2 intraoperative complications that were related to anesthesia. 2 patients who underwent hysteroscopy developed laryngospasm immediately after they were transferred to the recovery room, and those patients did have to stay overnight after the procedure. All other patients were discharged just as we do for all the surgical management of early pregnancy loss on the same day. Obviously, we were very interested to see what is going to happen with the operative time in the 2 groups, and I think we were not surprised to see that all the operative time for the hysteroscopy were longer when we compared them to suction curettage. However, when we look at the number themselves, we see that those numbers are actually within an acceptable range for such a procedure. So for the hysteroscopy group, the overall operative time, so from entry to the operative time to finish of the procedure and transfer the patient to the recovery room, the mean time was 36 minutes, so it's something that we think as reasonable for such a procedure. And the surgical time itself, so the time to remove the pregnancy for the hysteroscopy, was a mean time of about 10 minutes. So I think longer time, but still something that we can see as a reasonable, acceptable time. And then our main really focus was on what's going to happen to the uterus when we took a look at it after 6 weeks on an office diagnostic hysteroscopy. And I think we were very surprised to see the results as far as the adhesions. We were expecting to see about a 20% rate of adhesions in the suction group, and we were surprised to see a rate of 45% of adhesions in this group. Most of them were mild adhesions, so just, and I'm going to show you some examples, so very mild adhesions. We did have 2 cases of moderate adhesions in the suction group. In comparison, in the hysteroscopy group, we had only 2 patients diagnosed with adhesions. One was a mild adhesion, and the second a more moderate type of adhesion. And of course, this difference was statistically significant. So let's go over some examples of how the uterus looks after 6 weeks. This is an example of just a normal hysteroscopy. This is what we want to see in all our patients. Nice endometrial lining, no adhesions, nice tubal ostia. So this is all normal. The second example is an example of mild adhesion. This is the most common type of adhesions that we saw. So just adhesions located near the right tubal ostia. And of course, those type of adhesions we can take care of doing a see and treat approach. And usually they have a very good prognosis. The third type of adhesions that we saw were adhesions located at the area of the inner cervical os or the lower uterine segment. This is what you can see here. So initially we thought maybe this is a little bit more complex. We don't know what's going on in the cavity. But when we go through to the uterine cavity, we can actually see that the cavity itself is normal. So no adhesions in the cavity. All the adhesions were at the area of the internal cervical os. And lastly, 2 cases of more moderate type of adhesions following suction. In this case, there's an obliteration of the, mostly of the left side of the cavity, as you can see here. And lastly, the severest case of adhesions that we saw in this study, it's a patient who was gravida 1 para 0, who had suction, just a regular suction for an early pregnancy loss. And on her follow-up, we saw that the entire cavity was obliterated after 6 weeks. This was managed in the OR. We very carefully opened up the adhesions, as you can see here. And then we had a little bit of surprise, because what we saw after we removed most of the adhesions, and you'll see that in a second. So what we basically saw that the gestational sac is still there. And this is probably why she had such severe adhesions after such a short, you can see just the sac is still there. And this is, of course, after a suction. And I think we can probably say that this would not have happened if this patient had a hysteroscopy procedure. I mean, I don't think we can think that this would be there for a hysteroscopy. So the sac is still there, even though she had a suction with an ultrasound guidance, just the traditional way that we do it. Our next outcome was evaluating for retained products of conception on the 6 weeks office hysteroscopy. And here we had another surprise, because we thought that we're not going to see a lot of retained products after hysteroscopy, but we were actually seeing quite a bit of them. So initially, for the hysteroscopy group, almost 20% of patients had suspected RPOCs. Most of them were removed in the office using either miniaturized instruments or the tissue removal device, and all were, of course, sent for pathology. And actually on pathology, what we saw that half of those cases were decidual tissue and only 10% were actually true RPOCs. And that probably means that because we don't take as much of the decidua when we do hysteroscopy, we probably see more abnormalities inside the cavity when we look at it after the surgery. But again, not all of those cases are true RPOCs. For the suction group, a similar number of cases with true RPOCs. And the difference between the groups in terms of the RPOC was not statistically significant. So to conclude, hysteroscopy for the surgical management of early pregnancy loss appears to be feasible. It's a safe procedure. We can complete it in a very high percentage of cases using the technique that I showed you. We definitely see reduced rates of intrauterine adhesions. Unfortunately, we were not able to reduce the rates of RPOCs. We think that this could be due to the learning curve. It's a new procedure. We were really just getting the hang of it. There are certainly additional concerns, and I think all of us are asking yourself, is this going to replace suction for early pregnancy loss? And there are concerns. The cost is higher. You do need surgical expertise. It's not an easy hysteroscopy. You need to have the availability of the equipment. But if we do use this, and I think for selected patients, especially those with recurrent pregnancy loss, we do have the advantage of combining the procedure with embryoscopy and with genetic sampling. And last but not least, as you all know, doing such a study is a work of many people, doctors, nursing staff, administrative staff. So I really want to thank all my wonderful team, and a special thank to Dr. Maya Nao, who was the primary investigator for this study. You're amazing. Thank you.
So, and I'm happy that there is also Chuck Miller in the room, who was one of the first who talked about the possibility of using hysteroscopy for retained product of conception and then even for missed abortion. So last but not least, perfectly in time, I give the speech to Ursula Catena. But before that, I think I have to do a question to all of you. Who has said at least once in your life to his boyfriend or girlfriend, I leave you because I love you so much? Who? Castellacci, you, a lot of time. Natalia, come on. So, because this is what happened to Ursula, because Ursula was in Naples many years ago, 8-10 years ago. She was one of the most talented endoscopic surgeon of our team. And when they asked me some recommendation about good doctors to build up a service of advanced hysteroscopy in Rome, I was very confident to propose her name. She told me, why you want to leave me alone? So I said, no, because I love you so much. And so please go to Rome. But at the end, it was her success, because is an example of a mentee, which becomes even better than the mentor, because if you go to Rome, at Gemelli Institution, you will see that she created probably, I think, one of the most, if not the most advanced hysteroscopy center in the world. And even the title of her presentation is the example of someone who is going over the borders of the uterine cavity, because she's going to speak about ectopic pregnancy, cesarean scar pregnancy. These are the real new frontier of hysteroscopy. So Ursula, without crying, come here, and so...
Hello everybody. Okay. Perfect. Thank you for the introduction, but I have no words to describe you. So we will speak about ectopic pregnancy and cesarean scar complication, a surgical perspective. First of all, thank you, Medtronic, for the nice title. Niall, thank you. So, first thing that we have to evaluate is the real terminology. So we know that ectopic pregnancy are normally extrauterine pregnancy, but also inside the uterine cavity, we can have some types of ectopic pregnancy, such cesarean scar pregnancies, cervical pregnancies, intramural pregnancies, and interstitial pregnancies. And surely this is something challenging to treat in our daily practice. The more important of these, sure, is cesarean scar pregnancy that can be also a scare pregnancy for us when we saw this kind of patients. And what is, first of all, the definition? Is a quite new entity, and it is a tissue of the, it develops inside the tissue of the scar after a previous cesarean section. About the numbers, we can see that approximately 0.15% of patients can have a cesarean scar pregnancy, and it constitutes the 6% of all ectopic pregnancy. But we have to differentiate two types of cesarean scar pregnancies. So an endogenic one and an exogenic one. What is the difference? We can have a cesarean scar pregnancy that is implanted on the scar, so a type 1 endogenic type, and the progression can be normal to the cervicoisthmic space or within the uterine cavity, and we have the worst one, that is the cesarean scar pregnancy implanted in the niche. What's happened? Okay, so the type 2 or exogenic type, in which we have a fully implanted cesarean scar pregnancy within the niche with possible protrusion in the vesico-uterine interface or even into the parametrium. This was a nice publication on American Journal of Obstetrics and Gynecology, in which they differentiated the outcomes of these two entities. So group A implanted on the scar, and we see that we have 5 cesarean sections with the normal placenta and only one case of cesarean scar, cesarean section and hysterectomy. And we have the group B, so the cesarean scar implanted in the niche, 11 patients, that they ended in 10 cesarean section with hysterectomy for placenta increta or percreta, and an hysterectomy during the pregnancy for vaginal bleeding at 20 weeks. And so we see that these are the most scare situation in which we can arrive. And what about the management of these women? Surely we have not real clear guideline about this. We can see in internet that we can find also a cesarean scar pregnancy registry, but there is no widely accepted treatment modality. So we have two options normally. We can wait, or we can to move on and decide what to do. We see a lot of paper quite a lot of paper about this situation, but if we see the guideline of the Society for Maternal Fetal Medicine, they recommend against expectant management of cesarean scar pregnancy, and an exception could be the fetal death or the evidence of an early pregnancy failure, but also in this case this could require several months for the spontaneous resolution, and it could lead to uterine arteriovenous malformation, or we know for a situation of enhanced myometrial vascularity, now so called, and also in that case we have to do something to solve this problem. This was another paper in which we see the outcomes of cesarean scar pregnancy, and we see that if it left untreated, this can lead to severe hemorrhage, uterine rupture, and the need for hysterectomy. What about the recommendation? We see that the operative resection under ultrasonographic guidance is one of the way in which we can treat it. Then there is intragestational sac methotrexate, systemic methotrexate, but we see that we have several options that we can have in consideration, but there is not a clear line. In this other study published on fertility and sterility in 2017, we can see that 14 different approaches are described to treat cesarean scar pregnancy. Between us, 5 have the better result, and between these we can find hysteroscopy. This was a paper published by the group of Attilio some years ago, and this flowchart I think that could help us. So hysteroscopic appears to be effective and safe in pregnancy with an early gestational age, and so we can decide how to manage also on the base of the gestational age of the patient. And here we can see also this paper in which we can see all the randomized trial on the treatment of cesarean scar defect. The star is the results of each work in which we see what is the best option on each of these randomized control trial, and we can see that it is very different the situation between the different studies. So uterine artery embolization, transcatheter arterial chemioembolization, local methotrexate, systemic methotrexate, and hysteroscopic resection. And also here we can see that in the study in which Attilio compared hysteroscopic resection versus ultrasound-guided dilation and curettage, we can see that surely hysteroscopy have much more better result with a succession rate of the complete removal of the pathology of 100% and just one case, 3.7% of intraoperative complication, and 0 cases of hysterectomy if we use hysteroscopic resection. Then in 2021, Paolo Casadio published this video article in which he went to inject locally inside the gestational sac methotrexate, and then he removed the pathology with the tissue removal system. And you see here the injection inside the sac. Sorry. Okay. I have not to touch the cable. Okay. I want to show you the injection. In different point of the gestational sac. Then he entered with the scissors, the gestational sac. And then he did the resection. Then our group published another case in which we used tissue removal device system to remove the cesarean scar tissue after uterine artery embolization with reabsorbable tissue. You see here ultrasonographic. First of all, I don't know who of you will go there with a curette with a less than 2 millimeter free myometrial margin up to the apex of the niche. So here you can see with TrueClear system that you completely remove all the tissue inside the niche, and also with the blunt tip of the instrument you can go and completely detach the tissue from the niche. You see that you have the cavity here down on the left side. Okay. So we remove also some tissue inside the uterine cavity that was completely down and posterior and lateralized to the left side. And then you see the big niche. And here we went with the blunt tip of the tissue removal device system to completely detach all the pathological tissue. Okay, I want to show you the last part of the video here, in which you see that we completely remove all the pathology. I think that everybody of us can tell that this cannot be possible with a blind curette. Then we published this other video article in which we used simultaneously hysteroscopy and laparoscopy, because this patient had a cesarean scar pregnancy that infiltrated the margin of the cesarean scar. So we firstly remove the tissue from inside, and then we opened the cesarean scar defect, and we reconstruct the inferior segment of the uterus under hysteroscopic guidance to maintain the perviety of the cervical canal. And last, another extrauterine pregnancy that we can treat hysteroscopically is the interstitial or cornual pregnancy. You see the three-dimensional ultrasound, and maybe not everybody can think that this can be completely treated by hysteroscopy, but look at the hysteroscopic picture. So here we see this big remnant inside the uterus. And also in this case, just using a tissue removal device, and I always use the TrueClear system with the soft tissue blade that works very well. We go to treat all this tissue. You see that also in this case, you completely detach very safely, no bleeding, the tissue from the uterine wall. You enter between the myometrium and the tissue. And in few seconds, look now how it develops inside the uterus of this patient. Because I went back and look here. So that was the other ostium, and look what happened to the uterus of this patient when she get pregnant and developed the pregnancy in the cornual area. You see here finally the ostium. You finish your work very precisely. And we have our final view. So concluding, what we have to remember? We have to remember that uterine ectopic pregnancies can be safely treated in some cases by hysteroscopy. The more common surely is cesarean scar pregnancy. In women after a cesarean section, the frequency to develop a cesarean scar pregnancy is 0.15%, which constitutes 6% of all ectopic pregnancies in patients after at least one cesarean section. Endogenic type 1 is the cesarean scar pregnancy implanted on the scar, but the worst situation is the exogenic type 2 cesarean scar pregnancy that is implanted in the niche. The clinical outcome clearly differed between these two entities. If left untreated, the cesarean scar pregnancy may lead to severe hemorrhage, uterine rupture, and the risk of needing of hysterectomy. No consensus on the management in this moment, so the combination of methotrexate and DNC appears to be a safely and effective method to treat this entity, but the hysteroscopic resection appears to be a safe and effective treatment too, and we see that in expert hand we can have a perfect result. Primary local methotrexate injection followed by hysteroscopical removal of the cesarean scar pregnancy with the tissue removal device may be a valuable treatment for women who desire pregnancy in the near future. Thank you.
So, good job, Ursula, as all the other speakers. So we have some minutes for question. So I see the end, I recognize the end of Chuck Miller. So Chuck, please.
So wonderful presentations, two especially areas that I'm interested in. Dr. Smordik, I've had a 10% retained rate as well, so it's very interesting. We're now together, we're at about nearly 250 patients, so it's going to be very interesting with your increased use of the technique if you can lower it, and tell me how, because it seems like that cavity is bare. One more, Ursula. You know I respect the hell out of you. I really, really do. You are just a brilliant hysteroscopist. And I feel like I'm Bob Dylan taking out an electric guitar at Monterey when everybody only wanted to listen to folk music. I'm going to say the L word. I think with cesarean ectopic pregnancies, the type 2s, the management should be laparoscopic because it allows you to repair the C-section defect, the isthmocele, at the same time. And I just can't get past that.
You mean simultaneously? Normally, I control these patients after 3 months because you know that the isthmus are reduced, and then we decided the possible laparoscopic treatment, but normally not simultaneously. But I understand
our experience. We reported this in
you directly correct in
We've had
in the same
virtually
time.
everyone pregnant intrauterine.
However, I think what is important is the early diagnosis of this pregnancy, because in order to avoid severe complication, both if you try hysteroscopically or laparoscopically, what is important, that's why I think that the preparation with methotrexate is important in order to reduce the vascularization of the trophoblast and to reduce intraoperative bleeding. in such situations.
Methotrexate's important. UAE scares me because of the subsequent decrease in pregnancy rate after UAE.
Yeah.
And in the type 1s, you do have to be careful that pregnancy doesn't migrate and becomes an intrauterine pregnancy. So that has to be watched.
So Lawrence, the microphone.
This one. Chuck, I have about 250 as well first trimester terminations with the trochlear soft tissue. You and I have done webinars together in the COVID era, but just a quick thing is, we had a patient last week with a type 2 and an ongoing fetus at 10 weeks where you could see the placenta starting to infiltrate the bladder. And after 5 of us talking to her, we suggested to her that we should terminate the pregnancy. She'd had 3 cesarean sections before. So she walked off and went off for a second opinion, and I don't know what's happened to her. But how do you manage a patient who at 10 weeks is a type 2 with a fetal heart ongoing?
Yes, you know that in our institution we have also a problem because we are a Catholic hospital, so termination of pregnancy is not allowed, but in that case for maternal risk, sure, it's the only thing that you can evaluate.
Jamal, no, Mila.
Okay. Yeah, he allowed me just, I want to share that I have a patient. She's currently with 19 weeks. She had 2 cesarean sections previously, and she was pregnant. I was already prescribing the methotrexate and everything. And then she said, no, I'm very religious and I don't want to terminate the pregnancy. Okay, God gave me this present, okay. So now she's 19 weeks. And the placenta is in the niche, and the bad case that Ursula said. And now there's only 3 millimeters of bladder wall. It's already in the bladder. Okay, it's 19 weeks, but we're gonna see. I'll tell you after about 10 weeks, I hope, what's gonna happen. That's it.
Okay, I have a question
Jamal?
for Professor Catena. At the end of the procedure, when you arrive at the saline, with this device, you can sometimes have some aspiration of the saline and lead to a bladder injury. Because when we do that with the cold loop, which is visual curettage and not blind curettage, we cannot lead to that because we see what we do, we don't aspirate, we only mechanically detach the
You know, sure, you can use a cold loop, but I do not agree with you, because if you use correctly a tissue removal device, if you see you have not this problem. And also normally when I am in that very small area, I use the blunt tip with the window in the cavity and not in the part where there is the myometrium and the bladder. But if you use correctly, he will not aspirate in 1 second nothing.
Okay. So I think that the key message that it should come out from this symposium is that if 5 years ago probably we were discussing how to remove the polyps, the small myoma with tissue removal device, now you have seen that the indication for this instrumentation have changed. And when at the beginning we said, yes, tissue removal device can be used by everyone because short learning curve. Is it right? But mostly for easy procedure. But step by step, expert surgeons are using this device even in more challenging situation. So it is right to discuss, Chuck, it's better laparoscopy, hysteroscopy, methotrexate, how we remove. So these are challenging situations. But I think the message is that these tools that are fantastic to be used, keep attention when you use in challenging situation, but not for the instruments, but because the situation is challenging and it requires experience. If you treat the cesarean scar pregnancy, independently. I did the study with the mini resectoscope. Ursula is using the tissue, but you have to be prepared to the complication, whatever it is the instrument that you are going to use. So the message is that we are increasing the indication in hysteroscopy, and of course the new technology, the new instrumentation are now used in a very different clinical scenario, and more are difficult, more you can have some complication. And I think that from this meeting you have seen Lawrence treating type 2, type 3 myoma, Noam treating missed abortion, Ursula treating ectopic pregnancy. 5 years ago, these indications were not only off-label, they were even not imagined. And so look the beauty of hysteroscopy, that step by step, year after year, we are increasing the horizon of this technique, but we have to handle the situation. Sorry if there is no more space for question, because otherwise we will finish, and tonight there is the party. I know that is a late party, but we shouldn't do the party here in the auditorium.
You can have the last word.
Oh, Lawrence, close.
Last word. And I think the take-home message here is, sorry, Mark, the take-to-work message is, when we're dealing with difficult cases, I do all my cesarean section, not many, but I've done in a couple of years, a few with mechanical tissue removal, but I always do it with abdominal ultrasound, full bladder, so that I've got full control from above and full control from below. I know you've got to try and keep your left eye on the ultrasound machine and your right eye on the stack, so you become squint, but at the end of the day, don't forget your ultrasound. Thank you.
And last but not least, because here in the room we have the person because of which we are here today, I would ask a big applause to Mark Hans Emanuel that had this great idea a few years ago. Mark, stand up. If Mark was doing a travel in Italy at that time, probably we will not be here, because you were thinking about other stuff, sun, beach, but he thought about Morse later, and so that's it, we are here. So thank you.